Okay, this week we're going to be talking about the intervention for these children in the emerging language stage. So, developmentally speaking, they're about 18 to 36 months, but they actually might be a little bit older than that. But this is where they're exhibiting their language skills or in that emerging language phase. And we have determined that based on our assessments as discussed previously. So, this is going to discuss the products, procedures, and context of intervention for children with emerging language. Okay, so last week we reviewed the assessments and how do we determine what the level of functioning is for this child or these children that we're serving. So how do we move from assessment to intervention? Once we decide to provide intervention, what should it be and how should it be delivered? Well, we know that with this being early intervention services, that it should stay a family-centered practice, and that most of these children will receive an IFSP, that stands for that Individualized Family Service Plan, under that birth to 3 population that is served under the IDEA regulations. So most of the time, the SLP's role will be to provide language assessment and services in communication development, unless the SLP is designated as the case manager. So if you're the case manager, you have more responsibilities, but if you are not, your sole provision is language assessment and services and communication development. So as part of that, we need to consider the role of the parent. The parents, they can be primary providers of intervention through programs that teach parents clinician-directed approaches to eliciting language. They could use a hybrid approach, or they could use child-centered methods, and we'll talk about the different types of methods a little bit later in this discussion. But so the parents can be the primary providers instead of the SLP. We know that we don't want to imply that the parents are the problem here, as we've discussed much before. We're not judging on the parents that the child's having this difficulty because of something they've done. This is just a means of them to be able to provide the intervention in place of the SLP, because we want to create the most optimum language learning environment. But we do know that the research says that normally speaking children don't need to talk either, in the sense that their needs too are anticipated and nonverbal communications are consistently responded to and rewarded. They learn to talk because it's part of their biological programming. And so the children who are delayed have that biological programming there too. It just might not be functioning at that same age range that we expect it to be functioning in. And that we see that there are very few differences in mother-child interactions between normally speaking toddlers and their late talking peers. So we know there's not a correlation necessarily between a child who's not developing language and the impact of how much the mother is interacting with that child, because we see it across environments, language-enriched environments. But we want to encourage parents to do as much intervention as they feel is appropriate for them and their child. What's most beneficial for them. Some parents might feel too intimidated and may not feel like they are capable of providing interventions, and some parents might embrace it and say, sure, let's go for it. I'll do whatever I need to do. But there is a value to the clinician-directed intervention, or the intervention provided directly by an SLP. That can have an important secondary effect, such as improving social skills with children, so they're interacting with somebody besides their parents that can improve their social skills. It can also reduce parent stress. I can tell you, as a mother of 3 children, to being very young, I would be very stressed if I had to be responsible for providing language intervention to my youngest child, in addition to all the responsibilities I have for my other 2 children, my full-time job, and being wife, mother, parent. So that I would be I'm not necessarily intimidated, but I would feel overwhelmed and stressed if I had to do that role of being the interventionist as well as the parent. So, and I'm sure there are many other parents that feel that way. So that could be how reduced parenting stress is if the clinician was providing the main intervention. So appendices 7.3 and 7.4 in your textbook, they're at the back of the chapter 7, discuss general training resources for parents of toddlers. So you have, I know we talked about the Hanen program that's available, but there's many others listed here that's available for you to do with parents to train them on how to work with their children, and then videos for training parents and teachers with toddlers as well, as in 7.4. But the family should be, even if the family does not provide the main intervention, the family should be actively involved in setting goals for intervention, and the clinician should ask parents what they want the child to learn most. And there, at the same time, there's a role for focused, direct intervention. So the family's involvement capacity, at the minimum, needs to be helping us set those goals and interventions, what they want that child to get the most out of for therapy. Okay, so intervention for emerging language, intervention products, the goals for emerging language. So we're going to look at these 4 areas as we talk about developing intervention goals. We want to look at development of functional and symbolic play and gesture. Then from there, we'll move to the use of intentional communicative behavior. Next, we'll look at language comprehension, and then finally, we'll look at production of sounds, words, and word combinations. And of course, word combinations are the highest level skill that we would be targeting, because that would be 2-word utterances, which doesn't occur until after the child has at least 50 words in their vocabulary. So we're starting at the bottom and working our way up in a hierarchical fashion. So let's look at developing play and gesture. If the child is not demonstrating any appropriate use of objects of symbolic play and gestures, as outlined in Table 7.2 and 7.3, so that was listed in our earlier modules. If they're not developing that and demonstrating that, then we want to have a foundation for symbolic function and reciprocity anticipatory sets to be established, as we would be done with the prelinguistic child. So based on our assessment, we'll look at their play functioning ability, their gesture ability, and if they're functioning below 18 months, they're not at that emerging language stage, they're still at that prelinguistic stage. So we might need to address things on the lower level. If they are functioning at 18 months to 24 months, there are different types of symbolic play and gestures that we're going to be looking for them to be demonstrating. So if the child is showing reciprocal behavior, the next step is early conventional and symbolic play and didactic gestures. And so didactic gestures, pointing predicts first word use, so gestures complement spoken form. Symbolic play would be play schemes emerge, gestures first, self-directed symbolic play, play schemes. Symbolic play would be actions carried out on an object to depict the object and its function. And then representational play, representational gestures emerge, such as putting hand to mouth to indicate once bite of mom's cookie. This is all on Table 7.3 on page 241, talking about those different types of play. So how to develop symbolic play and didactic gestures. In Table 7.8, we are given a hierarchy of taxonomy of play behaviors to be taught in intervention for toddlers. So where do we start in working our way up? And it's taught primarily through modeling. So the clinician or the parent is modeling this type of play. So let's look at, first we have functional play with pretense, use of actual or miniature objects in the manner in which they were intended without the reality-based outcomes, such as pretending to eat from an empty spoon. The next step is substitution. Object substitution, which is use of one object as if it were a different object. So picking up a spoon and pretending it's a phone, holding a block on the ear and pretending to talk on the phone. There are several levels within substitution. And sequencing, we have functional play sequence, a substitution sequence. Functional play would be putting a doll on a bed and covering it with a blanket. Substitution sequence, putting a doll on a piece of paper and covering it with a washcloth. And finally, talk and play. Confirmatory vocalizations. So you be the doctor and I'll be the mommy. This is the child telling us this, but of course it's the clinician. We're modeling this. And even through all those play steps that we're going through, even if the child's not using words, we're supplementing that with words to narrate essentially the type of play that we're demonstrating. What we do it through modeling, we model the type of play we want the child to use. We want to develop conventional and symbolic play and gestures. It's an ideal context for parental involvement. So this is a great way to get parents involved and parents playing with the children, and a great way for them to provide the interaction. Parents can model play and gesture behaviors. And we want to encourage parents to use gestures as they talk with toddlers, which can enhance their children's word learning. So in the accompaniment of gestures with words has been shown to enhance word learning in toddlers. Okay, so once we've addressed the play and gestures, we're going to move on to using intentional communicative behavior. So remember, intentional means the child communicates intentionally to try to get our attention, to comment on something. They're not just babbling and playing or vocalizing. So James, my infant, is not an intentional communicator yet. Cecile, my 3-year-old, is. She's been for quite some time. And Mason, my nephew that you watched on the video, was in that emerging intentional communication stage because he was pointing at something and saying something. And according to Parent Report, he says mama when he's talking to mama. So intentional means we want to get something out of our behavior that we're doing. So we want children to initiate communication, but we have to get them to do it. All right. So that's a challenge in trying to get intentional behaviors. So it's called the spontaneous parent talks. We want children to initiate communication, but we have to somehow get them to do it. So here we can use communication temptations. And remember those communication temptations? You put something just out of their reach, where they have to try to gesture or comment on it to try to get what they want. You do not require specific responses, but do structure the situation, provide multiple opportunities and models for the child. You can demonstrate temptation to the parent and ask parents to respond as we want the child to respond as well. So that's a hybrid method of intervention because we're not requiring a specific response. Another type of intervention that we can use to elicit intentional communicative behaviors is the pre-linguistic milieu teaching methods, as outlined in box 7.4. In this type of method, we could arrange the environment to elicit the child's communication. So we want to put something just out of the child's reach or outside of its normal location. So if it's a favorite toy, such as a baby doll, and we move the baby doll from the floor to the shelf, the child has to find the baby doll and try to draw our attention toward the baby doll to indicate that that's what they want us to get. So the desired materials are in view, but out of reach. We want to focus on and follow the child's attentional lead, attend to and talk about the toys selected from the child. So the child is leading in the toys we're selecting, and we follow that child's lead. We want to embed instruction and ongoing interactions, building social routines, engage the child in repetitive, predictable games such as patty cake, peekaboo. Encourage parents to play the games at least once a day with the child. We want to focus on specific target behaviors. So what we're trying to elicit from them, maybe it's a gesture of, it could even be a sign language of want or more, or the sign for doll, whatever they're trying to do, the specific target behaviors. If it's verbal, if it's doll, we might want them to say da, da, or point to doll, doll, doll. It would be like a approximation of want doll. We want to use prompts and reinforcements to elicit and maintain communicative behaviors. So we can have time delay prompts, which nonverbal prompts interrupt an ongoing turn-taking routine. We have gaze intersection and verbal prompts. So open-ended questions such as what and look at me. And we want to provide a long time for clients to give responses. Their suggestions at least 15 seconds to have a time delay. So we provide them at least 15 seconds for them to give us a response. And all of this has been shown to be highly effective, particularly with children and mothers who are already quite responsive to the children's communication attempts. The next type of therapy intervention we discuss is routine or script therapy. So you want to establish routines that within the child's expectations, such as peekaboo, I'm going to get you, and then you want to intentionally violate the routine to elicit a protest or correction from the child. So you can, if you're doing peekaboo, 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 where's mama? And then you wait for the child to respond to try to elicit something for peekaboo. You say, where's mama? Peekaboo, where's mama? And wait for a child's response. Then again, giving them at least that 15 seconds for response. So very scripted, something that they have that anticipatory set expectation established. And then the Hainan Center program is another program that follows this type of learning. More using intentional communication behaviors. If communication overall is low, we must be prepared to accept any form of behavior as conveying intent. Any kind of grunt, gesture, vocalization, anything that they do, we react as if it's intentional. And I know I do this with my autism spectrum disorder children that I work with that are about 5 years old, and I'm trying to get intentional behavior from them. So it might be blow bubbles, blow, pop, 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 blow. I'll take a mouth circle. I'll take a pointing gesture, anything that they indicate to me that they want me to blow more bubbles. And I wait and I increasingly up the ante, so to speak, for them to try to elicit more conventional words or behaviors. So we want to remember to work towards eliciting both proto-imperatives and proto-declarative functions. So we talked about proto-imperatives and proto-declaratives in the previous parts of this chapter. Proto-imperatives are addressed first because they are easier to elicit, and these were found in box 7-4. So if you can flip to page 259, that pre-linguistic teaching. That's the gesture model. Box 7-4 talks about arranging the environment to encourage their production of proto-imperatives. But the proto-declaratives are the ones that are most closely related to conversational, so that's what we're working towards. Proto-imperatives are first. Proto-declaratives are close to resemble a great majority of conversational speech acts. These acts are less frequent in the communication of children with a variety of disabilities as well. So we need to have strong, all right. So we need to have a strong, positive relationship with the child to elicit proto-declaratives because they involve the sharing the states of feeling and attention. So once that relationship is established, we can introduce novel events or objects to the child to encourage comments. New toys can be placed within established routines. Rolling a car instead of a ball. Routines can also be sabotaged with silly or unusual events such as pouring juice into a bowl instead of a cup at snack time. So while sabotaging a routine, we're trying to elicit a response from the child, a comment on what we are doing. Adults could also pay less than the normal amount of attention to a child by backing away or facing away from the child during interaction, which forces the child to do something to regain the adult's attention. However, this does not work well with children with ASD because they have that limited social interaction anyway. They aren't interested in re-engaging us. We have to do everything we can to keep them engaged because they're relatively indifferent to adult attention. We want to help children learn how to direct other people's attentions to topics on which they are focused. And we want to continue until the child produces more than one communicative act per minute. So you continue these types of routines and these types of sabotaging routines until they have one communicative act per minute, which is average for that typically developing children in that stage. For children who show relatively frequent expressions and a range of functions, we want to increase the maturity of the mode of communication. So they're past the level, they have one communicative act per minute. They're frequently, intentionally communicating. So our goal is to increase their mode of communication. So maybe they're used primarily gestures, and we want to use more vocalizations, or their vocalizations are primarily vocalic in nature, and we want them to have more consonants. So we want to attempt to elicit vocalizations and eventually conventional words. This is upping the ante, and we withhold responding until the child produces some type of vocal behavior when they're trying to elicit our attention. So we've moved from accepting any type of communication as intentional to having a specific type of communication to be intentional, a type of communication that has a consonant and vowel production. It's a vocalization beyond just a vowel, and it sounds, it's not necessarily a conventional word yet, but we're moving toward conventional words. We want to identify concepts and intentions the child is already expressing with gestures and present higher level forms along with an imitation of the child's gesture. So essentially, we're augmenting gestures with increasingly mature vocalization. So if the gesture, for instance, is the sign for more, we're not going to accept just more from that child because we know they're intentional. We're going to want to accept mo, more. Some type of approximation that has that that consonant, and that could be ah, could be o, type of vowel. We won't accept because that would be considered a grunt. We want that consonant attached. Vowel-only forms of vocalization should be treated no differently from gestures. Only vocalization with consonants should be acknowledged. And by upping the ante, we can require a closer approximation of conventional words. There are some exceptions to this because we don't want to extinguish gesture use. We'd be wiser to help children augment their gesture use. I'm sorry, I already said that. One exception to this, though, is children who use maladaptive means of expressing their intentions. Because of the inherent danger of such behaviors, we will not be able to simply accept or ignore the maladaptive form of expression. Functional communication training has been shown to reduce these types of behaviors in toddlers. So we always want to acknowledge the client that the message was received. And with the maladaptive forms of communication, we need to provide alternative means quickly and to make clear the form of client use was not acceptable. It's important that these more acceptable forms of expression have been acquired, that we honor them. So we're not necessarily doing all that delayed response or waiting for them to give us a specific response and upping the ante if they're a child that uses maladaptive forms. When I was on vacation, a couple that was with us, they have a child with a very rare syndrome, and she is verbal, but she has limited communication. So her maladaptive form was when she couldn't express exactly what she wanted to, she would bite her arm or her hand. And she was very responsive to redirection of, no, we don't do that. And in general, we saw her doing it when the baby cried and she wanted to tend to the baby, or she wanted us to tend to the baby and to stop crying. Not because the crying bothered her, but she wanted to make him okay. She wanted to make him better. So that is whenever we saw that maladaptive behavior, was when she couldn't adequately express what she wanted changed in her environment. And so the parents and us, my husband and myself, and even Kennedy and Cecile, we trained them to respond very quickly. No, don't do that. Yes, we know. Baby's crying. Look, he's okay. He's okay. We would have to reassure her, just because he was crying, that didn't mean he was hurt, that he was okay, because she was very attuned to that. So it was a good example for me to be able to share with y'all too, for those types of behaviors. So something about these approaches for trying to elicit intentional communicative behavior, they all involve a refusal on the adult's part to anticipate the child's needs and delaying of the adult's provision of goods and services to the child. So for instance, if the child is used to the adult responding when they use a gesture, and we've upped the ante to require a vocalization that's intentional from the child, that might be a little frustrating for the child if that was always occurring in their environment, and we actually might end up doing some harm if the parents aren't responding to the child's needs. So we want to discuss with the parents if they feel comfortable delivering this type of intervention with a child, and that they need to continue to anticipate and respond to the child's needs at least some of the time. This type of therapy or an intervention should only be done within certain contexts at certain times, when it's the most optimal time for communication intervention. So they're not going to be doing this throughout the day. Now, I can say it's an SLP. Naturally, I'm doing this. I did this with Cecile, and I'll do it with James when he gets to that point, that I up the ante with them and I require more of them, but still within the context of responding to their needs when they express it, even if it wasn't the form that I was desiring. So there are times and places for everything, essentially, and we don't want the parents, if they are providing this intervention, to be doing only this all the time, because it actually hinder the child's communication development. So this is one area where direct service by the clinician may be appropriate if we feel like the parents won't understand how to make that distinction between when to up the ante and do a refusal and when to respond to the child, or if the parents don't feel comfortable with it, then the clinician directed services would be appropriate. Then there are also some suggestions for a parent-administered program of early language intervention called First Words in Table 7-9. And this would be where the activities, the parents are assigned activities. They have forced choice, which they ask the child to choose between a liked and disliked object. They get a desired object only if the child tries to label it or imitates the parent's labeling. Step 2 would be developing the vocabulary. Clinician chooses 20 words of vocabulary to begin with. Parent asks what WH questions when child is attending to the referent for one of these words. And parent gives item or complies with child's request only if the child tries to label item or imitates parent's label. And finally, incidental teaching is when parent asks child to label or imitate parent's labeling any object or activity child is attending to or requests, and over which parent has the control. So that is one type of program you could do with parents that elicit these types of responses about that refusal unless we get that desired response. And it's important to note that all practitioners accept the view that the clinician-centered approach would be appropriate. So it says Whitehurst argue that parents should be taught to ignore all gestures and vowel-only communication in children if they're at that point of intentional communication with consonants. They advocate giving parents structured activities to do with the child to elicit speech. But this could be an area that was up for debate within clinicians. I, as a clinician, don't personally believe that the parents should use only one approach, because I don't think that only one approach fits for any child. And I think that you could do more harm than good if you weren't responding to the child's needs appropriately, at least sometimes, for those interactions. So that was developing intentional communication. So now let's look at developing receptive language or comprehension. Indirect language stimulation, or ILS, is appropriate for children in the 18 to 36 month developmental range. It allows the client to try out comprehension strategies and develop expectations about conversational structure. ILS is an ideal vehicle for giving the child a clear set of examples for how language can be used to describe experience. Oops, sorry. Let me go back. There are parent training materials that are available, again, in appendices 7.3 and 7.4. The training should focus on helping parents learn to follow the child's lead by imitating actions, sounds, and words, and providing words to match the child's actions and activities. The standard ILS techniques include expansion, so you take what the child has said and expand it. So doll, you can say baby doll, or yes, my baby doll. My baby doll is in bed. Extension, extending the sentences into long sentences. Recast, so you take what the child says and you recast it in the correct form. So Cecile still does her going to do that. Her is there, and I'll say, yes, she is there. She is going to do that. So I'm constantly using recasting with Cecile, even now when she's 3. And open-ended and verbal reflective questions. So using open-ended WH questions would be that. It can be taught to, and you could do all of these, teach these standards, these techniques to parents through modeling. So even though parents usually use these types of methods naturally, we want them to provide super normal levels of facilitative stimuli. So they're overstimulating their children because these children have exhibited these deficits. We know that very high levels of facilitative input can help to allay any lingering suspicion parents may have that we feel they have failed to give adequate stimulation to the child. In other words, we're saying, we know you do this already. We want you to do it to the extreme, overdo it, overstimulate them to try to help enhance that language development. We want to tell parents that to provide simple one-word labels for whatever the child is focusing on or referring to, because that way the child is getting bombarded constantly with labels and words and how to increase that vocabulary. And then box 7.5 gives guidelines for parent training. So these 11 steps tell us how to train parents in these methods. Be sure parents understand specific goals before beginning training. Involve as many family members as possible. Delineate parent and clinician responsibilities clearly. Explain the purpose of the procedures. Collect baseline data. Model procedures for the parent. Provide feedback to the parent. Monitors parents' use of the procedures. Encourage parents to make incidental use of procedures in natural day-to-day activities. Maintain regular contact with families. And monitor the effectiveness of the intervention. So by providing broad range of models in play and other facilitative contexts, we can continue to build children's receptive vocabulary. All right, so how do we develop sounds, word, and word combinations? And this will have phonological skills, first lexicon, word combinations, and pre-literacy development. So initially for phonological skills, our primary goal, we said this over and over again, of phonological intervention in the early stages of language development is the enlargement of the consonant inventory and the range of syllable shapes the child can produce. We are not trying to increase their correctness. We're trying to increase their range of consonant production, because even typically developing children in the 18 to 36 month range, more than likely are not going to produce all sounds correctly. They're going to have some they're going to delete blends for consonant blends. They'll have a consonant deletion or a cluster reduction rather. They'll have consonant deletion when they might have final consonant deletion. They can have backing or fronting behaviors such as tap for cat. They're going to have gliding. You're probably not going to have their R's very well developed. And we don't expect all speech sounds to be developed until around, between ages 4 and 7, essentially. So we're not looking for all correct speech sound production. We're looking to enhance their consonant inventory. So by imitating child vocalizations has large effects on increasing vocalizations. And for children that have less than 50 words, we can do babble games. So we imitate what the child is saying, and we can use a better, more clear production. So if the baby's saying ba, ba for ball, we can say, yes, ball, see the ball, big ball, roll the ball. The clinician can add new consonants based on the order of acquisition of consonants by normally developing children. So we know that there's a consonant production that's typically developing. Not always, because sometimes you have an L developed before a K sound, and that's not what's necessarily anticipated. But in general, late talking toddlers acquire consonants and syllable shapes in the same order as normally developing children. So by 18 to 24 months, the late talkers produce most stop, nasal, and glide consonants, but few frequentives or liquids. So we want to do stops and nasals and then glides. And then once a full range of stop and nasal consonants is present in the child's babbling repertoire, the clinician can begin to introduce some fricatives. So we're going to go in that progression of what's the easiest to most difficult. So again, the goal is not to get child to produce particular sounds, but only increase the consonant inventory. When speech is a goal for intervention, phonological work should focus primarily on expanding the repertoire of sounds and syllable shapes rather than on correcting errors relative to adult target words. So any conventional word approximations that children with developmental delays are producing ought to be rewarded. We reward any good word approximations. The goal is to get the child talking, more and more, increase the vocabulary, more than any type of speech sound drilling, particularly at this level. And I take that philosophy even at the later developing stages, at ages 5, 6, 7, the school age. I'm increasing vocabulary before I'm increasing speech sound production, because I believe they're too intertwined, and a delay in phonological development is directly correlated to delay in vocabulary development. So the goal is to get the child talking and increase the range of phonological structures available to support this talk. So how do we develop the first lexicon, the vocabulary aspect? So consideration for choosing first words to teach. Choose words that are similar to those used first by normally developing children. So we know that close to half of first words are nouns. So we need to at least have half the words we're targeting be nouns. The other half are not nouns, but that can be adjectives, pronouns, verbs, all those other types of labeling, nouns or labeling, non-nouns. So words that express relation. So we had that Brown stages that we looked at in the assessment component, that those types of words, the relational type words, the articles. We need to teach words that can be used to talk about the relations among objects. So pronouns, function words, that, the, verbs, help, is, and relational words, more, all done. Teaching children these kinds of words give the child the opportunity to express more communicative functions than simply dating. It also provides a set of words that can be readily combined with others into two-word utterances when the child is ready to make that step, which is the next step. And we can see in Table 710 words for the first lexicon that you can choose from. No, all gone, away, those are rejection words. Cessation or prohibition, no, stop, all done. Recurrence, more, again. Existent, this, that, there, what. Action objects, get, do, make, throw. Locative action, put, take, up, down. Attribution, big, hot, pretty. Naming, I, it, you. Possession, my, mine, what. We want to, so they need to be functional and fulfill a broad range of communication purposes that can use to accomplish social goals for that child. So words should be chosen to encode ideas and interests that the child already has. They can be identified through analysis of the play behavior and also through parent interview and parent input about what the child is interested in. So if it's driving cars during the play assessment, drive will be an accessible word. Although a simplified pronunciation, die, should be expected. So we're not looking for perfect productions here once again for these phonological productions. We need to consider phonological shape and composition of words to be taught. We want to match words to the child's consonant inventory. So most of the words in Table 710 are either consonant vowel or consonant vowel consonant shapes. It's important. that would help us. They have the stops and the nasals because those are just easier words for the child to say initially. So that's could be also one of their commonly occurring first words in children. And it has new sounds in an inventory. New words containing these sounds could be added. So what is the best procedure for increasing early vocabulary? We have child-centered, hybrid methods, and clinician-directed methods. In child-centered, many clinicians favor this because it involves natural play context. It just seems to be how children are learning words and language anyway. So we introduce activities and objects to which the targeted words can refer and have clinicians provide numerous models of the use of the target words to refer to these objects, activities, and their relations. Choose words based on the child's current knowledge and interests. So it's basically a play and modeling word production within that play context. So a child will learn words for ideas already being expressed through play based on play assessment. So that that child's already playing with the car and driving the car and doing intentionally, ka, for car. You say, yes, car, drive car, we drive car, let's drive car. And hopefully you'll get, car, drive, vroom, vroom, vroom. And hopefully you'll get an imitation of die, boom, 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 something of that nature from the child. So hybrid methods such as MIGU teaching method and script therapy, they're clinician-directed and they're child-centered. The MIGU teaching models, which we've talked about over and over again, organize the environment so the desired objects, activities must be requested or commented on by the child for them to get what they want. Another method is script therapy, which is the clinician and child engage in verbal routine or pattern of actions that involve the use of words targeted for child's early lexicon. All right, so for example, a clinician can go through a series of steps to place the child's name tag on a board to indicate that he or she is present each day of the intervention session. The clinician can accompany each action in the sequence with a simple utterance, "You're here, your coat, take it off, put the tag on, you put your tag on." When the routine is overlearned, the clinician can violate an aspect involving one of the target words, or the SLP can use a close technique, providing the routine language but leaving a blank for the child to fill in the target word. You put your tag. Where do you put your tag? You put your tag on. Where do you put your tag? You put your tag. And hopefully the child finishes with saying on. And you can see these in table 7-9 on page 261, and that was that parent learning first words activity. Is that right? Yeah, that's right. Okay, sorry, just making sure. Now we also can use a clinician-directed approach, which is drill play, or clinician-directed modeling with child imitation. But this seems to work best with children with low IQs, better than the more naturalistic approaches with that children. The more naturalistic approaches work better for children with higher IQs. And I do have a tendency to use a drill or drill play type model with my children with lower IQs. Another example of clinician directed, but it's also script therapy, so it could be considered hybrid, would be association method, because association method's very scripted. You say the words, what do you see? I see a cat. I see a ball. I see a dog. So it's very, very scripted therapy, but it's clinician directed, but it's also child centered because you have that child switch the role of the child for teacher. So it has been shown to work with children as younger than 3 years old. It's not one of my preferred methods for children of this age nature, but for children who might be in that developmental level, who may be older than 3 but can have that focus, I definitely can see a benefit for that. But essentially what we take home from this as far as what type of approach is appropriate, well, toddlers with language delays benefit from a range of approaches, so long as focused attention of language is present in the activities. So there's no hard and fast rule, one size fits all. We need to determine which approach or mix of approaches works best for the particular client. It's going to depend really on what works best for that child and that child's family. And we do know that receptive vocabulary is typically in advance of expression in the emerging language period. So So we don't want to deprive them of hearing a rich amount of mix of words. We want them to constantly get bombarded with words and hear words throughout the day, even if we're concentrating on only listing a few of the words in the child's production. We want to encourage parents not to limit their word use to lexical items the child can say, but urge parents to provide a range of labels for objects, events, and relations in clear here and now context. All right. So how do we develop word combinations? So again, this is once that child reaches that 50-word milestone, we have 50 words, so we're ready to start combining words into 2-word phrases. First, word combinations are used to talk about the semantic relations they have already been encoding with single words. So the child already has these 2 words and single words, and we want to put them together. Most early 2-word sentences convey a small range of semantic relations that are common across children and related to their current knowledge and interests. So we can look at table 7.7, which is back on page 254, and that was the Brown stages, the semantic relations, attribute, entity, big shoe, mommy knows, dad hit, action object, agent object. So those 11 Brown early stages, those most 2-word combinations are fall within those categories. So child-centered approaches to develop 2 words involve the use of indirect language stimulation. When a child produces 1-word utterance, clinician expands it to encode the same relation child intended with a 2-word phrase. So the child might say eat with a doll, hold the doll up and spoon to feed the doll and say eat. And the clinician said, yes, doll eats, the doll eats, eat, doll, eat. Or the child were playing with a car and bumped into another car, saying bump. The clinician remarked, yes, the cars bump, or you bump the cars, bump, cars bump, cars bump. And I love certain books for that type of eliciting that behavior, like Go Dog Go, that really scripted type of fill in the blanks. The child, for this, no imitation is required, but the goal is to provide models of 2-word utterances that map ideas the child is already expressing in play, and hopefully that child starts imitating it and starts expressing those ideas as well. In hybrid approaches, the clinician responds to a child's incomplete utterance, such as doggy, with a contingent question, where is doggy? A child responds to the question with another fragmentary marked bed. Clinician takes the 2 pieces produced by the child and expands them into a more complete utterance. Yes, the doggy's in the bed, doggy in bed. But again, the child is not required by the clinician to imitate this expansion. Then we have enhanced milieu teaching and conversational recast, which has been shown to be effective in eliciting multi-word speech. And you can see examples of those in Table 7.9 and Table 7.11. So Table 7.11 is 265. Suggestions for a parent-administered program of early word language intervention and word combinations. So the Table 7.9 was first words. Table 7.11 is how we do word combinations. Introduce word combinations, shift your world from verbal to social. So you say, oh yeah, good job. You had the child label objects and activities in which the reward is attention and praise rather than receipt of the object or activity. Level 3 is storybook reading. Level 4 was open-ended questions. So that's a scripted approach that you can use with parents or with your own therapy. In a script therapy approach, we can use song play. So you can do, where is Thumpkin? Where is Thumpkin? Where are you? Where are you? Here I am, how do you do? And the child has to fill in the missing verse. So, where is Thumpkin? Where is Thumpkin? The child would say that. Here I am. The child said, here I am. It's very scripted type of play. So the clinician might violate it after the child's learned it and say, what is Thumpkin? And delaying the production of the line. The child corrects and says, no, where's Thumpkin? Where's Pinky? Cecile's favorite one is Daddy Finger. Daddy Finger, where are you? Here I am, how do you do? And so I was working with one of my 4-year-old clients this year on that same type of goal. And I'd say, Daddy Finger, and he'd go, where are you? So he would finish the utterance. And he was higher level than this level, but it's the same type of concept where they have to finish what they're singing. So that's a scripted therapy approach. Then the focus stimulation is another approach that's effective, in eliciting these. Clinician-directed approaches have also been shown to be effective. It's a confederate of the clinician. A confederate of the clinician is used as a model. So, such as a parent or puppet. The clinician has a parent there or a puppet there. The clinician, after pretesting the child on target structure, gives the model a set of pictures not used in the pretest and asks the confederate to tell what's happening here. So if it's the parent and the parent sees the picture, the parent says, boy drink, girl eat, cat walk. After 10 or 20 of these descriptions, the client is asked to talk like the model, so talk like the parent, and describe a similar but not identical set of pictures. So that is one method of the clinician-directed approaches, because the clinician is pre-selecting those tasks that you're teaching instead of following the child's lead and the child's engagement in play. Environmental Language Intervention Strategy, or ELI, is another clinician-directed approach. It's found in box 7.6. It involves some extensions into semi-controlled versions of conversation and play. So parents work on the same language goal for 15 minutes in each condition of imitation, conversation, and play. Not pally. Sorry for that. So phase 1, imitation. Linguistic and non-linguistic stimuluses are paired. In phase 2, conversation, the non-linguistic stimuli are the same as in the imitation phase, but the linguistic stimulus is a question rather than a request. So what am I doing? In phase 3 is play. While the child's playing with the materials used as non-linguistic stimuli in the imitation and conversation phases, the adult asks for the conversational response in an appropriate context. The child plays with the toy bunny. The adult asks, what are you doing? And the child should be responding with pay with bunny, pay bunny. So all of this is leading into an issue that commonly comes up, is whether the linguistic input should be well-formed or contain the deletions that children are likely to make in these utterances, resulting in telegraphic productions. But we found, though, that what the research is finding is that sentences children hear should contain all the required grammatical elements and should not contain deletions children are likely to make. This helps to focus on weak, strong syllable pattern in English and facilitate children's identification of important units in the speech stream. Well-formed grammatical input cannot do any harm and actually may do young children some good. Now, I will say that I'm always giving the correct grammatical form, but I might reduce the form oftentimes when I'm trying to get an imitation for the child. So if it's yes, doll eat. Look at the doll. The doll is eating. The doll can eat. Let's eat, doll. Eat, doll, eat. So the reduced form, even that's correct, would be eat, doll, eat. It's 2 words, or 3 words really, but 2 concept words. And it's not that complete grammatical form, but that's when I'm trying to get that child to give me that production. So I might reduce the form for an imitation, but I am doing a complete grammatical form with the initial language responses. All right. And then finally, let's look at pre-literacy development. So the emerging language period is when typically developing toddlers acquire important experience with books and print. So we do have ways to use storybooks in working with toddlers and their families to build early language and literacy skills. We can work collaboratively to select books with parents that are developmentally appropriate and attractive to toddlers, and also be sure that families have access to these books. So that's a critical component. Developmentally appropriate books that I think of are like Go Dog Go, any of those early Dr. Seuss books, but even those reduced, the board books that are, Go Dog Go has the big 60-something page Dr. Seuss, or it's not Dr. Seuss, but I think it's E.B. White. But it's the big book, but then we have the board book that's much shorter and much easier for the child to attend to. Chicka Chicka Boom Boom, Brown Bear, What Do You See? Very scripted patterns of reading that the child can actually finish. Polar Bear. So those are all Eric Carle books. There's another one I got recently from my nephew. Oh, Mr. Brown Can You? That's one of our favorites. And it has a lot of imitation. Boom, boom, boom. Mr. Brown is a wonder. And the child has to make sounds and say, can you make these sounds? Like boom, boom, buzz, buzz, pop, pop, fizz. Uh, and I can see this in Cecile because she'll get a book and she's playing with the book and she has a book they read. By the station in the morning, stand the puffer bellies all in a row. Vroom, vroom, beep, beep, off they go. She's been doing this song for 6 months. I do not have the book. It's at daycare. I've never seen this book, but I know what that book says because she's constantly imitating that book's pattern whenever she's picking up a book and reading. So any kind of books that have rhyming patterns and very predictive type text. We want to teach parents routines for interactive reading strategies, such as pointing out connections between pictures and text, stopping as children fill in elements after they have heard the story a few times. We want to encourage parents to use exaggerated intonation and stress during reading to highlight important elements in the text. Encourage parents to develop play activities around the themes for storybooks. So after reading One Fish, Two Fish, Red Fish, Blue Fish, children can be encouraged to find red and blue things in their house. Expose children to decontextualized talk relating to the stories they have heard on their own day-to-day activities, such as talking about times the child has seen a fish. For SLPs, our role in pre-literacy development at the emerging language stage consists of encouraging families to expose their children to interactive storybook reading and helping parents develop shared book reading strategies. I would also say that we can use books to facilitate communication and language, such as that imitation and that scripted therapy. A book is a great way to get that reaction of that scripted therapy that we're looking for the children in the initiation of communication or in that two-word combination stage. But the most effective characteristics of pre-literacy development encourage children's engagement and active participation in shared reading experiences. So anything we can do to enhance toddlers' opportunities to get experiences with literate language and literacy artifacts is helpful for the children in this stage because they're already at higher risk for reading difficulties just by being identified with a language delay or deficit early on. So we want to be sure that aspect is included in our intervention approach. And that will be it for this week. If I can stop it.